Any questions? Mr. Dickinson.
I don't have a question. I have a comment. I see this is an item that asks for money to prepare an assessment, analysis, and estimate, and I anticipate seeing this again in May after the May revise. We've got to ensure that there's safety for all in our institutions. It does require some balancing of interests in doing that, but we also need to make sure we're respecting due process. And so, as we see AB 1340 develop, I think that's something that, from the committee staff point of view, we're going to want to look at. And if we're moving forward with this, which, in my judgment, would be prudent under defined circumstances, then we want to make sure that we are respecting constitutional rights in that endeavor. But we need to make sure that everybody is safe.
Right. And we've given you some staff comments and questions that hopefully over the next period of time we'll get even stronger answers to those questions regarding this for the budget item. I want to thank those of you who came to present for this particular item, item 4. So thank you very much. This item 2 is held over until we get additional information. We're now at item number 5, Patient Management Unit.
Great. Mark Beckley, Department of State Hospitals. We're requesting 10 limited term positions and $1.1 million general fund to establish what we call a patient management unit. As Dr. Warburton described in her introductory comments, the department is still in the process of diagnosing our needs and our deficiencies, and the lack of a patient management function is something that we identified as a very key critical deficiency. What a patient management unit would allow us to do is it would allow us to search for available beds within our system, place patients into those beds as they become available, rather than just having the courts refer patients to specific hospitals that may not have the beds. The other thing it will allow us to do is look at the specialized needs of patients. So if you have a patient who's hearing impaired, visually impaired, has special medical needs, we would have the ability to centrally place that patient into the hospital that would best serve those special needs. Currently, it's a very arduous system. As patients get referred to individual hospitals, these special needs will sometimes be found after the fact. We then have to administratively re-refer them to another hospital, and that takes time, and it's just very, very inefficient. We also think that having such a unit in place would have enabled us to proactively identify the increase in the IST population and possibly develop and implement plans to proactively address that issue rather than what it feels like reactively addressing the issue now that we see the large growth in the waiting lists for those populations. This unit would also be good for problem resolution. So if we identify a patient who has special needs in their existing referral, we could then re-refer them. The unit would also do a lot of data and research. We lack a data research for patient management currently. We use our fiscal staff to do this kind of research, but it would really be good to look at recidivism rates, average lengths of stay, increases by commitment types, increases by hospital on an ongoing basis. We do that during budget season, but we should really be doing that on an ongoing basis to stay on top of patient population trends. Finally, there's a lot of operational responsibilities that they would have, conducting ongoing outreach with the courts, with CDCR, with other stakeholders, speaking with the counties, keeping MOUs up to date with the counties and other stakeholders, and resolve billing issues with the counties. So we think that this is definitely a needed function. And in response to the staff questions about the appropriate vehicle to talk about patient placement criteria, we're open to those discussions, whether it's through statute, through regulations, through program guides. I want to assure the committee that our bias would always be to place the patient within their home communities, unless there's critical needs to place them otherwise in other places. So that is our patient management proposal.
Thank you. Any comments from LAO or Finance? None? LAO?
Thank you, Madam Chair. Sarah Larson with the Legislative Analyst's Office. We would recommend that the legislature approve this bill, but approve it along with the associated trailer bill language. So generally, we think the proposal is a good idea and would allow DSH to, as the department noted, place patients more quickly, potentially reduce lengths of stay, and potentially result in cost savings. However, we would point out that the department currently lacks the authority to fully implement such a patient management program. Under current statute, judges are allowed to commit patients either to specific state hospitals or to the system at large, just as they so choose. Until that's changed, the department wouldn't be able to fully take advantage of this program because judges would still be able to commit patients to specific locations, so the associated benefits of the program, such as specialization and reducing costs, may not materialize. Because of that, we would recommend approving the proposal along with trailer bill language clarifying that commitment to the state hospitals constitutes a commitment to the state hospital system rather than to a specific location.
Okay, sounds good. Any comments, Mr. Dickinson? Any public hearings? Okay, fine. This matter, too, will be held over for additional information as we get more information. We're now to item number...
And just by way of note, we do agree with the analyst that we do need language.
Right, exactly. Okay, and then we'll get trailer bill language. Issue number 6.
Okay, third-party billing function. The Department of State Hospitals is proposing 15 limited-term positions and $1.9 million general fund to establish a third-party billing unit. Again, as we diagnose issues and deficiencies within our department, this is another issue that really needs some additional function and help. So pursuant to Welfare and Institution Code, Section 7275 through 7279, the DSH is required to assess a patient's ability to pay for their care and treatment. To the extent that patients are unable to fully pay for the cost of their care, DSH is responsible for pursuing other fund sources that could help defray the patient's cost of care, such as other state and federal fund sources. The primary fund source that we rely upon currently is federal Medicare reimbursements. On an annual basis, the DSH can collect up to $10 million in federal Medicare reimbursements based on the current number of patients that are eligible to receive Medicare. Historically, DDS has a unit that pursued these collections on our behalf. However, with the growth of the state hospital population and the decrease in the DDS patient population, DDS no longer has the resources to continue this work on our behalf. So we are requesting that we build this function and take over this responsibility. Based on our estimates on the total amount of annual Medicare reimbursements we could collect, $10 million, when we looked at the 2011-12 fiscal year, we only in fact collected $5.7 million out of the $10 million that we were entitled to. So we lost out on $4.6 million. And that was predominantly due to rejected claims, claim errors, lack of training in clinical staff and local staff in terms of how to actually properly claim for these reimbursements. So this unit would validate that the hospitals are indeed billing for Medicare eligible services. We would research and resolve problem claims. We would provide training to the hospitals to make sure that this work is being conducted properly, and we'd keep up to date on federal policy and procedures. It's a cost-effective proposal. We think that we would net out between $2 to $3 million based on current estimates if this proposal was approved.
Okay, sounds good. Any comments from Finance or LAO? Okay, fine. Any comments, Ms. Dickinson? Seems to be fair. Any public comments? Okay, this item is up for vote, but we don't have a quorum right now, so we'll wait till our quorum reappears, and we'll vote on this item. We're at item number 7 now.
Okay.
Also up for vote.
OSHA compliance. So Department of State Hospitals requests 5 limited-term positions and $502,000 general fund to allocate 1 OSHA compliance position to each of the 5 standalone state hospitals. Ever since the tragic death of one of our psychiatric technicians at Napa State Hospitals 4.5 years ago, DSH has been under review by Cal OSHA. Cal OSHA has paid numerous visits to our facilities, and during that time span, we've been issued 38 citations in the total amount of $316,000. The problems range from blocked electrical panels, blocked fire extinguishers, to ineffective patient escort policies that could put the safety of our staff at risk. Last year, we reached an agreement with Cal OSHA to resolve all outstanding safety ice citations. One of the main components of the settlement was to adopt a comprehensive safety framework that would cover all of our facilities, and then the facilities need to implement what are called local injury and illness prevention plans to encompass the components of the safety framework. So what we're proposing is for each of these positions to finalize the completion of these injury and illness prevention plans and to conduct ongoing training of all hospital staff on health and safety matters to make sure that we're up to date on the local policy and procedures for safety.
Okay. Any comments from Finance or LAO? Okay. Any comments? Any public comments? Okay. This item, too, will be held over for a vote today. We'll vote on this today when we get our quorum back. We're down to item number 8.
Okay.
I'm Jamie Mangrum. I'm the Chief Information Officer for the Department of State Hospitals. DSH is requesting 2 permanent positions and $7.4 million general fund in the coming fiscal year and $2.3 million in 2015-16 to implement a medical grade network. As we move in the next 2 years to an electronic health record away from paper, eliminating paper, we have to make sure that our clinicians have the same reliable access to that patient information as they do to paper today. Put things in perspective, in the past 30 days, we've had 9 hours of complete network outage statewide, where if we had deployed an electronic health record, our hospitals statewide would have not been able to access patient records for that entire period of time. This project will put the redundant network pathways in place that will eliminate that as a risk as we move electronic and out of the world of paper.
Okay, any comments from any of our finance LAO? No? Mr. Dickinson? No? Any public comments? Loving it, huh? In the back, okay. Me too. Well, thank you. We'll hold this item over for voting as well, item number 8. We'll hold that over for voting on item number 9.
As your consultant pointed out, when we made our reductions to meet budget conditions, one of the unfortunate things that happened is that we did, in fact, eliminate the program that you're talking about, and that's adult ed in state hospitals. It's unfortunate. We felt it was a very difficult decision. There clearly are things that they can do that would help the system, but we cannot recommend that we add those positions back because we're still under pressure to make our budget. But I just wanted to give credence to the analysis that there were things that would be nice to have, but we just can't ask for them.
Okay. Any comments from LAO or finance? Okay. Staff? Any comments from Mr. Dickinson?
The question is posed about what we know with respect to the value of adult ed, including its therapeutic value. Can you comment on that from the department's point of view?
It's not incorrect that there actually is a therapeutic value to this kind of provision of service. It's just that when we came down to making judgments about whether we could have clinical care or not, it didn't pass. I think that the staff consultant covered the issues that are clearly there. It is something that we would very much like to do, but we cannot ask that it be done.
But your conclusion is reached as a budgetary matter, not as a programmatic matter.
That's correct.
Okay.
So you're saying that I can understand in the world of limited resources, but if there are resources, would you find, I assume there's value in having adult education in the facilities?
Yes.
Would it fit into your overall plan in terms of what you're looking at in terms of assisting individuals to rebuild their lives and hopefully leave these institutions someday?
Yes.
Han Wang,
Yeah.
Department of Finance. It's currently the administration's direction to continue to exercise fiscal restraint despite the improving economy. So we would not be in support of this proposal at this time.
Okay, I understand that, since it wasn't their recommendation. It's clear. Obviously, we'll talk about it some more. I think we find some value in adult education. I know when it was eliminated, there was considerable concern in elimination of it, the proposal, and even though we are exercising fiscal restraint, as I've said before, when we eliminate things, not because they don't have value, but because we don't have money, then when we come back and have money, we should reevaluate those items that we eliminated and make a determination as to whether or not they had some value. If we exercise fiscal restraint on all items, we wouldn't add anything to the budget, and we leave all things as they stand. But clearly, we're better off than we were before. We're not whole. So when we look at this program, we're looking at not only what exists and how to make it more effective, but if there were things that we got rid of that would have obviously enhanced the care of the individuals there, then we're looking at those things as well. So we'll continue to look at it. We'll hold it over. We'll probably ask more questions about it to see if something that we do want to try to add to the budget and try to rebuild the programs that were there. Okay, item number 10, capital outlay projects.
Okay, Mark Beckley, Department of State Hospitals. I will provide a brief overview of the status of each of our cap outlay projects. The first project mentioned is the DSH patent perimeter fence. So this project would include the removal of the existing perimeter fence and guard posts and the construction of a new double security fence. Currently, the architectural engineering contract is expected to be approved by DGS by the end of this month. We expect that working drawings would be completed by August 2014 and that the construction would be completed shortly after the construction drawings are completed. On the second item, the Atascadero seismic upgrade. So this is a seismic retrofit of the east-west corridor that affects 579 licensed beds at DSH Atascadero. The retrofit would include the construction of steel-framed lateral supports at the upper third portion of the corridor of the building exterior. And then our seismic retrofit, this would reduce our risk from a level 5 to a level 3. We're about to engage in the preliminary planning phase, and this is expected to be a 3-year project. Item number 3, the Napa security fencing. So this includes courtyard gates and security fencing, improving those courtyard fencing structures. This will improve security within the secure treatment area of DSH Napa as well as the local community. We anticipate the completion of preliminary plans by the end of April, and then we'll move on to the working drawing phase. And again, this is anticipated to be a 3-year project. Item number 4, Metropolitan fire alarm upgrades. This is to upgrade the existing fire alarm system at DSH Metro. A contract will be executed by DGS at the end of April. That's when we anticipate it to be completed. And then we'll be working through environmental reviews to begin the project. And then we'll begin the preliminary planning phase. And that covers our projects.
Okay, fine. Thank you. Any comments from Finance or LAO? Okay. Mr. Dickinson, any questions? Mr. Mansour, any questions? Any public comments? Yes.
Kobe Pizzati with Merch Bassoff and Associates, representing California Association of Psychiatric Technicians. We just support the capital outlay on these projects. Thank you.
Thank you very much. Okay. No other comments, and that item obviously is to be voted on today. Thank you very much. We have remaining. We have the item 6, 7, and 8 to be voted on, and now item 10. We have a quorum here thus far. Mr. Mansour is here, so we'll vote on those items. If I can get a motion for item number 6. Is there a second? No second? Okay, second, because you're going to vote against it. Okay, I'll second it. Roll call.
Weber,
Aye.
Chesbro, Dickinson, Grove, Mansour.
Okay. We have item number 7 that is still in need of another vote. Mr. Chesbro will be item number 7. So moved. I'll second it. Roll call.
Weber,
Aye.
Chesbro, Dickinson, Grove, Mansour.
Okay, that one's out. Item number 8. Is there a motion? Second. Okay, it's been moved in second. Roll.
Weber,
Aye.
Chesbro, Dickinson, Grove, Mansour.
Item number 10. Second it? Second. Okay, second from Mr. Mansour. Go ahead. Roll call.
Weber,
Aye.
Chesbro, Dickinson, Grove, Mansour.
Okay. We'll leave it open. I think you have one vote to item number 2 you can add on to. And we will leave the roll open for Mr. Chesbro to return to vote. Okay. Having nothing else, the roll will be kept open, but our hearing basically is, we will not adjourn because we have to wait, but you can leave.
Thank you.
Thank you.
No problem.